I am Dr. Zsolt Szabó, consultant hand surgeon from the hand surgery centers in Budapest and Miskolc in Hungary. Welcome to this training video on the preparation injection technique and follow-up procedure for treatment with Xiapex. This video is designed to demonstrate how the Xiapex injection should be used in clinical practice for the treatment of Dupuytren's contracture in adult patients with a palpable cord. Learning the technique in this film is important to ensure safe and effective treatments with Xiapex. When you watch this video, please ensure you have the accompanying training brochure with you. The palmar fascia is the center of activity in Dupuytren's disease. The main anatomical components affected are the palmar fascia and the digital fascia. The longitudinal fibers of the palmar fascia are most commonly affected by Dupuytren's disease. They fan out and separate into 4 prytandinous bands. In the digital fascia, the central layer of the prytandinous longitudinal fibers splits into 2 bands, which extend onto each side of the flexor tendons. In Dupuytren's disease, normal fascia bands develop into cords, which shorten and lead to contractures of the joints. As well as causing contractures, some cords can displace neurovascular structures, putting them at risk of damage during any corrective procedure. There are several main types of cord. The prytandinous cord is the most common cord seen in Dupuytren's disease. It derives from the prytandinous band and causes MP contractures. The natatory cord develops from the natatory ligament and can limit abduction. The spiral cord can develop from various precursors, including the prytandinous band, the lateral digital sheath, and Grayson's ligament. This cord leads to contractures of the MP and PIP joints, usually in the 5th finger, but also in other fingers. In the palm, the spiral cord is superficial to the neurovascular bundle. In the digit, it can lead to displacement of the neurovascular bundle. The central cord has no fascial precursor and is usually an extension of the prytandinous cord along the fingers. Lateral cords originate from the lateral digital sheath and attach to the skin or the flexor tendon sheath near Grayson's ligament. Other types of cord may also occur: the abductor digiti quinti cord or isolated digital cord, retrovascular cords, and commissural cords. An understanding of these anatomical structures is mandatory when using Xiapex to avoid major complications.
I'm Chris Bainbridge, consultant hand surgeon from the Pulvertaft Hand Clinic in Derby, and I've used Xiapex in clinical trials in Europe. Xiapex is indicated for the treatment of Dupuytren's contracture in adult patients with a palpable cord. Please note that Xiapex must be administered by a physician experienced in the diagnosis and management of Dupuytren's disease. It's the responsibility of the healthcare professional administering Xiapex to ensure that they are adequately trained to deliver the injection. Xiapex, also known as collagenase Clostridium histolyticum, was developed as a targeted therapy for the treatment of patients with Dupuytren's contracture presenting with a palpable cord. The therapeutic activity of Xiapex is localized to the site of injection and therefore does not require systemic exposure to be effective. Xiapex is composed of 2 collagenases, which have been isolated and purified from the bacterium Clostridium histolyticum. Each collagenase within Xiapex works in a complementary way to cleave collagen chains and facilitate the disruption of the Dupuytren's cord. The first collagenase, AUX1, cleaves the terminal portions of the collagen chain, and the second collagenase, AUX2, cleaves the interior of the collagen chain into multiple segments. Dupuytren's cords are composed primarily of types 1 and 3 collagen, both of which are substrates for AUX1 and AUX2. If Xiapex is injected properly, the collagenases will cleave the collagen chains in the cord, causing it to weaken and break down. This allows the finger extension procedure to rupture the cord and correct the contracture. Importantly, the supporting structures of nerves, arteries and veins are composed of type 4 collagen, which is resistant to the action of Xiapex. Other soft tissues of the hand, including ligaments and tendons, are, however, susceptible to the action of Xiapex because of the presence of types 1 and 3 collagen in their own structure. Therefore, it is vital that those administering the injection have a full understanding of the procedures explained in this video to ensure precise application of Xiapex into the Dupuytren's cord to minimise adverse events. Before using Xiapex, it is important that the patient is made aware of all the elements of the procedure to be performed, the desired treatment outcome, precautions during the use of Xiapex, and the potential adverse reactions associated with the treatment. Patients should understand that there are some common adverse reactions that are likely to be experienced after the injection and the finger extension procedure. The most common are local swelling, bruising, and pain around the injection site. The majority of these will resolve within 2 weeks after injection. Therefore, the patient should be reminded at the follow-up visit that these reactions are expected and that they do not necessarily indicate an unsuccessful procedure or any permanent injury to the hand. Although rare, possible serious adverse reactions include tendon rupture or ligament injury. After injection, severe allergic reactions could occur, so the patient should be observed for potential anaphylaxis or systemic hypersensitivity until they leave the clinic. Xiapex is contraindicated in patients with previous hypersensitivity to the product. Patients should also be informed of the risk of reactions related to cross-reactivity with endogenous human matrix metalloproteinases. Prior to treatment with Xiapex, the following important precautions should be discussed with patients. The use of Xiapex is not recommended in patients who have received anticoagulants within 7 days prior to injection, with the exception of up to 150 mg of acetyl salicylic acid daily. In patients who have received tetracycline antibiotics within 14 days prior to injection, or in those who are pregnant.
Patients should also be informed that treatment with Xiapex involves both an injection and a finger extension procedure, which can take place 24 to 72 hours after the injection. If the cord does not rupture, a maximum of 3 injections can be performed to the same cord at 4-week intervals. Up to 2 cords or 2 affected joints in the same hand can be treated during a treatment visit. Finally, patients must be informed that following successful treatment recurrence can occur.
Before Xiapex is reconstituted for injection, the person responsible for preparing the solution should ensure that the following are easily accessible in the treatment room. To reconstitute and inject Xiapex, you will need 2 hubless syringes with 0.01 ml graduations and a permanently fixed 1/2-inch 26 or 27 gauge needle. One of these syringes is for reconstituting Xiapex and one is for the injection of Xiapex. Be prepared for any potential allergic reactions that may occur immediately following the injection. An epinephrine injection of 1 to 1000 for subcutaneous injection and antihistamine medication should be available. Set out in the treatment room the dressings for the patient's finger that will be needed post-injection. Please also have to hand a copy of the training brochure, which contains the preparation and injection procedure outlined in this video. Prior to reconstitution, the Xiapex package should be stored in a refrigerator at 2 to 8 degrees centigrade. Xiapex is supplied as a single dose in 2 glass vials, one containing 0.9 mg of a sterile lyophilized powder and one containing sterile diluent of 0.03% calcium chloride in 0.9% sodium chloride. Take the Xiapex package from the fridge before you're ready to use it and let the vial stand at room temperature, 20 to 25 degrees centigrade, for at least 15 minutes before, but for no longer than 1 hour. Before reconstituting Xiapex, check the package to ensure that the product has not reached its expiry date. All steps for reconstitution of Xiapex should be carried out using aseptic technique with sterile alcohol and in line with current local standard of care. Remove the protective coverings from both vials and swab the rubber stopper and surrounding surface of both vials with sterile alcohol. No other antiseptic should be used. Use a hubless syringe with 0.01 ml graduations and a permanently fixed 26 or 27 gauge needle to withdraw the diluent from the diluent vial. You will need different quantities of diluent depending on which joints you're treating, so ensure that you have confirmed which joint is to be treated. For an MP joint, withdraw 0.39 millilitres of diluent, and for a PIP joint, withdraw 0.31 millilitres of diluent. Now inject the correct quantity of diluent slowly into the Xiapex vial containing the lyophilized powder. Discard the syringe used for reconstitution and the unused diluent remaining in the diluent vial. Using a swirling motion, now dissolve the Xiapex in the vial until the solution is completely clear. Do not invert the vial or shake the solution. Inspect the solution for any particulate matter or discoloration. The reconstituted solution of Xiapex should be clear. If the solution is cloudy, discard it. The solution is now ready for injection. You may keep the reconstituted Xiapex for 1 hour at room temperature, 20 to 25 degrees centigrade, or up to 4 hours in the fridge prior to administration. If refrigerated, the solution must be allowed to return to room temperature for approximately 15 minutes before use. This section will explain how to inject Xiapex into a cord contracting an MP joint. Please note that reconstitution volumes and injection volumes differ depending on which joint the cord to be treated is contracting. For cords contracting MP joints, each dose should be reconstituted using 0.39 millilitres of diluent. The injection volume for cords contracting MP joints is 0.25 millilitres. The optimal injection site is the point where the cord is furthest away from the underlying flexor tendon and at a point where the cord is not intimately adherent to the skin. Usually, this is at the point of maximum bowstringing of the cord and is chosen to facilitate proper administration, taking into account the probable position of other non-targeted structures within the hand and decreasing the risk of skin tearing during the finger extension procedure. The optimal sites for injection into cords contracting the MP joints are shown. As a guide, this is generally between the distal palmar crease and the palmar digital crease. Note that in cases where both the MP and PIP joints are affected in the same digit, the cord affecting the MP joint should be treated initially, as successful disruption of the MP cord may decrease PIP contracture in the treated digit. Now you're ready to inject Xiapex. First, reconfirm the cord to be treated and ensure that the area for injection is appropriately marked to prevent misapplication. Administering a local anesthetic agent prior to injection of Xiapex is not recommended, as it may interfere with the proper placement of the injection and the ability to detect paresthesia in cases where the needle has been inserted into a nerve. Prepare the skin by wiping with an antiseptic and allowing it to dry. Using the second hubless syringe, withdraw the correct amount of reconstituted Xiapex solution appropriate for the joint being treated. For a cord contracting an MP joint, withdraw 0.25 millilitres of the solution. Insert the tip of the needle into the selected cord, taking care to keep the needle within the cord. Appropriate placement can be identified by the cord's increased resistance and gritty consistency. Be careful not to pass the needle tip through the cord to minimize the possibility of injecting Xiapex into neighboring tissues other than the cord. The needle insertion should be no deeper than 2 to 3 millimeters. As it may not be possible to feel a change in consistency as you pass through the cord, the depth of the needle may be a helpful guide. If the insertion of the needle causes paresthesia, or the needle is suspected to be in the tendon, withdraw the needle and reposition it into the cord. If placement of the needle is in question, ask the patient to slowly and carefully flex and extend the treated finger a few degrees at the DIP joint. If this causes movement of the needle, then it is likely in the tendon and should be withdrawn and repositioned. After confirming that the needle is within the cord, depress the plunger of the syringe, taking care not to push the tip of the needle through the cord. 1/3 of the total dose should be injected into the first injection site. If the needle is within the cord, there will be some resistance noted whilst the plunger is depressed. Withdraw the needle tip from the cord, keeping the needle tip under the skin, and reposition it to a slightly more distal location, approximately 2 to 3 millimeters. After confirming that the tip of the needle is again within the cord, inject another 1/3 of the dose. Again, withdraw the needle tip from the cord, keeping the needle tip under the skin, and reposition it a 3rd time proximal to the first injection, approximately 2 to 3 millimeters. After confirming the tip of the needle is again within the cord, inject the final 1/3 of the dose. Once the injection is complete, discard the syringe and any unused portions of the reconstituted solution. Do not store, pool or reuse unused portions of the reconstituted solution. This section will explain how to inject Xiapex into a cord contracting a PIP joint. Please note that reconstitution volumes and injection volumes differ depending on which joint the cord to be treated is contracting. For cords contracting PIP joints, each dose should be reconstituted using 0.31 millilitres of sterile diluent. The injection volume for cords contracting PIP joints is 0.20 millilitres. The optimal injection site is the point where the cord is furthest away from the underlying flexor tendon and at a point where the cord is not intimately adherent to the skin. Usually, this is at the point of maximum bowstringing of the cord and is chosen to facilitate proper administration, taking into account the probable position of other non-targeted structures within the hand and decreasing the risk of skin tearing during the finger extension procedure. The optimal sites for injection into cords contracting the PIP joints are shown. As you can see, care should be taken to inject as close as possible to the palmar digital crease, and the injection should be made no more than 4 millimeters distal to this crease. Therefore, the point of maximum bowstring of the cord within this area should be selected. This is particularly important for cords situated at the PIP joint of the fifth finger to reduce the risk of tendon or ligament injury. Note that in cases where both the MP and PIP joints are affected in the same digit, the cord affecting the MP joint should be treated initially, as successful disruption of the MP cord may decrease PIP contracture in the treated digit. Now you're ready to inject Xiapex. First, reconfirm the cord to be treated and ensure that the area for injection is appropriately marked to prevent misapplication. Administering a local anesthetic agent prior to injection of Xiapex is not recommended, as it may interfere with the proper placement of the injection and the ability to detect paresthesia in cases where the needle has been inserted into a nerve. Prepare the skin by wiping with an antiseptic and allowing it to dry. Using the second hubless syringe, withdraw the correct amount of reconstituted Xiapex solution appropriate for the joint being treated. For a cord contracting a PIP joint, withdraw 0.20 millilitres of the solution. Insert the tip of the needle into the selected cord, taking care to keep the needle within the cord. Appropriate placement can be identified by the cord's increased resistance and gritty consistency. Be careful not to pass the needle tip through the cord to minimize the possibility of injecting Xiapex into neighboring tissues other than the cord. The needle insertion should be no deeper than 2 to 3 millimeters. As it may not be possible to feel a change in consistency as you pass through the cord, the depth of the needle may be a helpful guide. If the insertion of the needle causes paresthesia, or the needle is suspected to be in the tendon, withdraw the needle and reposition it into the cord. If placement of the needle is in question, ask the patient to slowly and carefully flex and extend the treated finger a few degrees at the DIP joint. If this causes movement of the needle, then it is likely in the tendon and should be withdrawn and repositioned. After confirming that the needle is within the cord, depress the plunger of the syringe, taking care not to push the tip of the needle through the cord. 1/3 of the total dose should be injected into the first injection site. If the needle is in the proper location, there will be some resistance noted while the plunger is depressed. Withdraw the needle tip from the cord, keeping the needle tip under the skin, and reposition it to a slightly more distal location, approximately 2 to 3 millimeters. After confirming that the tip of the needle is again within the cord, inject another 1/3 of the dose. Again, withdraw the needle tip from the cord, keeping the needle tip under the skin, and reposition it a 3rd time proximal to the first injection, approximately 2 to 3 millimeters. After confirming the tip of the needle is again within the cord, inject the final 1/3 of the dose. Once the injection is complete, discard the syringe and any unused portions of the reconstituted solution. Do not store, pool, or reuse unused portions of the reconstituted solution.
Up to 2 cords or 2 affected joints in the same hand can be treated according to the injection procedure during a treatment visit. 2 palpable cords affecting 2 joints or 1 palpable cord affecting 2 joints in the same finger may be injected at 2 locations. When administering 2 injections in the same hand during a treatment visit, begin with the affected finger in the most ulnar aspect of the hand and continue toward the radial aspect, for example, fifth finger to index finger. Within each finger, begin with the affected joint in the most proximal aspect of the finger and continue toward the distal aspect, for example, MP to PIP. Each injection contains a 0.58 mg dose. If the disease has resulted in multiple contractures, additional cords may be treated at other treatment visits approximately 4 weeks apart. Each vial of Xiapex and sterile solvent for reconstitution should only be used for a single injection. If cords of 2 affected joints on the same hand are to be treated during a treatment visit, separate vials and syringes should be used for each reconstitution and injection.
When the injection is completed, place a bulky dressing over the treated hand and instruct the patient to limit motion and refrain from use of the injected hand. After injection, the patient should be observed for potential adverse reactions, including anaphylaxis or systemic hypersensitivity. Symptoms may include repeated sneezing, generalized erythema, pruritus or paresthesia, localized or generalized angioedema, difficulty breathing, neck or chest tightness, dizziness and syncope. After the observation period, 30 minutes, the patient may leave the clinic, providing he or she is stable and has exhibited no sign of systemic hypersensitivity or other systemic adverse reactions.
The patient should be instructed to return 24 to 72 hours after the injection for the passive finger extension procedure. Before they leave, you should advise patients to avoid using the hand and not to manipulate the joint contracted by the injected cord. In this section, we will look in detail at the procedure to disrupt the cord 24 to 72 hours after the injection and provide information on when you should repeat the injections if it is necessary. When the patient comes in, examine the treated hand, as in some cases, the cord will disrupt spontaneously. If, on examination, the cord has disrupted without finger extension, please give the patient advice on aftercare, as detailed in this video and the training brochure. If on examination the cord has not ruptured spontaneously, the following manual finger extension procedure should be performed in order to help facilitate rupture of the cord. Before commencing the finger extension procedure, the patient should be reminded that the cord may not rupture in one attempt, and if it does not rupture after 3 attempts to extend, they will need to return 4 weeks later for a subsequent injection and extension procedure. During the finger extension procedure, local anesthesia may be used at the physician's discretion, as the procedure may be painful or cause discomfort for some patients. Passively extend the finger by applying moderate stretching pressure to the cord. Apply the pressure for 10 to 20 seconds. The force exerted during extension of the finger should be uniform and persistent to the extent of the patient's pain threshold. Direct pressure to the site of the injection should be avoided as it will still be tender. During the finger extension procedure, patients with skin adherent to the treated cord may experience skin tearing as the cord ruptures. If skin tearing occurs, standard wound care should be administered. If performing the extension procedure on a PIP joint, the MP joint should be held in flexed position to isolate the forces of the extension procedure on the cord affecting the PIP joint. If cords of 2 affected joints in one finger were treated, perform the finger extension procedure on the cord affecting the MP joint before performing the procedure on the cord affecting the PIP joint. In some cases, the cord may not disrupt. In other cases, the cord may disrupt without a sound, or it may disrupt with an audible pop. If the first finger extension procedure does not successfully rupture the cord, a second and third attempt can be made at 5 to 10 minute intervals, as required when the patient is ready. No more than 3 finger extension procedures per cord should be attempted during the follow-up visit. If the cord has not ruptured after 3 attempts, a subsequent clinic visit should be scheduled approximately 4 weeks later for a further treatment with Xiapex. In total, each cord causing the contracture can receive up to a maximum of 3 cycles, each at 4-week intervals. Following the finger extension procedure, splinting is recommended since, in the clinical development program, patients were fitted for a splint to be worn at bedtime for up to 4 months. Patients should also be instructed to carry out finger extension and flexion exercises at home. They should be encouraged to return to their normal daily activities as soon as they feel able to, but not to undertake strenuous activities until advised. Standard use of analgesics, wound care, and management of bruising and swelling should apply to all patients, in keeping with the local standard of care. In the clinical development program of Xiapex, nearly all patients experienced adverse reactions. The majority of these were local reactions of mild to moderate severity, which resolved within 2 weeks post-injection. The most commonly reported adverse effects included edema peripheral, localized to the treated extremity, contusion, injection site pain, pain in the extremity, and injection site hemorrhage, manifested as bruising rather than frank bleeding. Patients may also experience skin lesions, tearing of adherent skin overlying the cord, occurring during the finger extension procedure. Caution should therefore be exercised in patients with Dupuytren's cords that adhere to the skin, as they may be at higher risk of skin lesions as a result of the pharmacological effect of Xiapex and the finger extension procedure on the skin overlying the targeted cord. The incidence of skin laceration was 29.1% for subjects treated with 2 concurrent injections of Xiapex and 8.8% with subjects treated with up to 3 single injections. Cases of skin laceration requiring skin graft after finger extension procedures have been reported post-marketing. Signs or symptoms that may reflect serious injury to the treated finger, hand, after injection, or manipulation should be promptly evaluated because surgical intervention may be required. The majority of serious adverse reactions reported in patients treated with Xiapex were confined to the treated hand. These included 3 cases of tendon rupture and 1 case of pulley injury. All of these above cases occurred in the treatment of cords contracting the pip joint of the 5th finger. In addition, 1 case each of tendinitis, complex regional pain syndrome, and sensory abnormality of the treated hand occurred. There is some other important safety information that physicians using Xiapex should be aware of. Xiapex is contraindicated in patients with previous hypersensitivity to the collagenase or any of the product excipients. Physicians should be prepared for any potential allergic reactions that may occur immediately following the injection, and medication should be available for use in the event of a systemic allergic reaction. 1 case of anaphylactic reaction has been reported in a post-marketing study. The use of Xiapex is not recommended in patients who have received anticoagulants within 7 days prior to injection, with the exception of up to 150 mg acetylsalicylic acid daily. The use of Xiapex in patients who have received tetracycline antibiotics within 14 days is also not recommended. Fluoroquinolone antibiotics have been associated with the potential risk of tendon injury, including tendinitis and tendon rupture. Therefore, caution should be used when administering Xiapex in patients receiving concomitant fluoroquinolone antibiotics. Finally, the use of Xiapex is not recommended during pregnancy, and treatment should be postponed until after pregnancy. As expected, when foreign proteins are injected into human tissues, an antibody response is elicited. There is a theoretical risk of interference between anti-drug antibodies against Xiapex and human matrix metalloproteinases. However, adverse events indicating development or exacerbation of autoimmune diseases or development of musculoskeletal syndrome have not been observed in the clinical trials. If it were to develop, this musculoskeletal syndrome would occur progressively and is characterized by 1 or more of the following signs and symptoms: arthralgia, myalgia, joint stiffness, stiffness of the shoulders, hand edema, palmar fibrosis, and thickening or nodules forming in the tendons. If you require further information on any part of the administration technique for the Xiapex injection, please refer to the training brochure which accompanies this video. The last approved version of the Xiapex SMPC and package leaflet is available on the website of the European Medicines Agency, www.ema.europa.eu.